Hypertension. Now, this is a result of liver failure. So, portal hypertension is not liver failure, but is a result of liver failure. So, it's important to have that distinction. Essentially, what's happened here is because of either an obstruction or the failure of the liver to function, that change in liver tissue that impedes blood flow into the liver, then subsequently, that blood flow is going to back up into the portal vein system. And you can see a picture here of the portal vein down here as it feeds down into the stomach, and a large portion of those vascular structures come from the esophagus, but also around the stomach as well. Usually the esophagus, because of the thin nature of that structure, because it's designed mainly for transport. It's not really designed for emulsification and stretching and expanding like the stomach is. So that structure there is usually the first ones that presents symptoms. But you can see where anatomically where that blood's going to back up into that portal vein. It's supposed to go in the direction of this arrow here, backs up in the portal vein, which then is going to put pressure on that vein and subsequently on these smaller vessels around the esophagus. Now, the other thing that's going to happen is a big portion of blood is plasma. So the fluid that helps constitute that plasma is also going to try to find a place to go. And in finding a place to go, it's going to end up in the peritoneal space between the visceral and parietal peritoneum and create what's called ascites. Now, the draw for the fluid there is this, as I mentioned earlier, proteins not getting metabolized by the liver. So this is a very proteinaceous fluid. Over time, some of that protein and albumin gets shifted into that peritoneal space. It doesn't move readily. So it's as a result of this high pressure, it moves into that peritoneal space, but it's not easy for us to move it back out, which means that protein is going to reside primarily in that space, and it's going to create an osmotic gradient that pulls fluid into that peritoneal space. So basic principles we talked about from the beginning, but here we're applying them to the vascular structures in the peritoneal space around the abdomen. So around the liver itself, around the kidneys, around the large and small intestine, around the stomach, all of that parietal area, that peritoneal area, all of that peritoneal area is going to have the potential to house these proteins and draw fluid in there. And that fluid that accumulates there is what we refer to as ascites. So, some of that I've discussed right here. Portal hypertension increases the capillary pressure and obstruction of venous blood flow. That's what I was referring to just a minute ago. And that produces vasodilation of this splanchnic circulation. So as that splanchnic blood flow dilates in response to the backup of fluid there, then it's going to surround and apply pressure on these abdominal organs. And as I said, protein is going to move across there. So this changes the ability to metabolize aldosterone in addition. So it's another side effect of this process. And that alteration in production is going to result in an increase in fluid retention. So we have a self-feeding problem. And as I mentioned before, since the liver's not synthesizing albumin, then what we have is a decrease in ultimately a decrease in serum osmotic pressure, because there's a lower albumin in the serum and there's more fluid in the system. So that albumin is going to move into that peritoneal cavity and serve as an osmotic driver. So this is what that would look like. So depending on the acute nature of the ascites, we may or may not be measuring the abdomen. So I mentioned record abdominal girth and weight daily. While that's true and is something we've done for years, you don't necessarily see people doing that all of the time. If you do that, one of the important things to do is to find a way to ensure that from staff to staff, from shift to shift, we're measuring in the same location. And commonly the way that's done is a piece of tape or a tape measure is laid behind the patient, and then you wrap it around the patient, you bring it together, and you mark on the tape where they meet, but then also where you lay it and have it approximating each end. You're going to mark on the sides of the tape so that everyone's laying the tape in the same spot every time. So patients may have striae, which striae are what you may hear people refer to casually as stretch marks. These are examples of striae here, as well as a herniated umbilicus, which is, you might hear people say, outie, but that's what we mean by herniated umbilicus. In this case, they don't just have an outie belly button, they have, their belly button has been pushed out from that increased intra-abdominal pressure. So the fluid will be assessed for shifting or dullness. You'll see physicians, providers percussing or actually pressing on it to see if it moves. And they may very well have, as a result of all of this fluid shifting, they may have fluid and electrolyte imbalances. And when we intervene on this and start doing a paracentesis and drawing some of this fluid off, that may also result in fluid imbalances or electrolyte imbalances that they may not have had before. One of the key things as we treat that is, if we're going to be aspirating that fluid off with paracentesis, as I mentioned here, is administering salt pore albumin, so that we're giving another osmotic equivalent, putting that in the vascular space. That's what we're doing now, putting that in the vascular space to help keep the patient from dramatically shifting fluid back, because the albumin in the peritoneal space is not moving. We can't extract that, but we can counteract it or balance the effects, I should say. We definitely would like to have a low sodium diet for these patients. They may or may not be on diuretics. That's going to depend on the efficacy of their kidney function. Some patients are able to manage or prevent the escalation of their ascites with diuretics. That may not be effective for some patients. And it may not necessarily, it's commonly reflected by kidney function, but sometimes people with good kidney function just don't get that much benefit from diuretics as far as managing their ascites. We typically have these patients on bed rest for a couple of reasons. One is because of this big distended abdomen, then their center of gravity, their balance is thrown off, so they are prone to falls. Not just because of that, but because of the associated weakness from the illness that's produced this and potential electrolyte imbalances. So they are a high risk for high injury if they fall. So that's one reason for putting them on bed rest. Another reason is not only are they high risk for injury, breaks, bruises, that sort of thing. Think about what's produced this. In most cases, it's liver failure. I said earlier, what are some bells and whistles that should go off with liver failure? And one of them is bleeding. So we can definitely have some big bleeding issues as a result of falls or other injuries if people are up and ambulating, moving around when they have this kind of ascites. We've already discussed paracentesis. There is a surgical procedure out there, transjugular intrahepatic portosynthetic systemic shunt. So what this procedure does is provides a shunt to attempt to divert some of that vascular pressure away from the portal vein. These are commonly done in patients where it's severe, as I hate to say as a palliative measure, but it's used as non-palliative in patients with NASH or non-alcoholic fatty liver disease, where there's not a chronic liver issue going on necessarily. And they may be done in patients who have alcoholic cirrhosis and that type as a palliative type intervention. These TIPS procedures are commonly done in centers where people are trained specifically for doing these. I'm not familiar. I don't know which institutions here are doing TIPS. Commonly, they have to be sent to a center that specializes for that type of procedure. And you can ignore that last item there. Now, esophageal varices, these are the results of the critical results, if you will, of portal hypertension. So when portal hypertension escalates and pressure is exerted on first the portal vein and then radiated back to these, or transferred back to these smaller vessels around the esophagus, what happens then is those areas can rupture and bleed, and they are at a very high risk of bleeding. If you have an esophageal varix, you can see the risk for bleeding is approximately 70%. I'll show you why in just a second. The mortality rate for a bleed as a result of a varix is around 10 to 30%. That's the mortality the first time. From a first episode, the first time you have anywhere between 70 to 90% chance of living. So that's pretty high risk for this procedure. They tend to bleed a lot. There's a lot of pressure on them, and it's pretty nasty looking when these things happen. Now, notice the way the risk goes up, the risk of death, the mortality risk from 10 to 70, from 30 at the low end to a 50% chance, basically 50-50 chance with a second episode of death and mortality. And when I show you some pictures, I will speak to this a little bit more as to why that makes sense. The way this shows up is usually shows up with either somebody having hematemesis or coughing up blood, or melena, blood in the stool. They may experience just general overall deterioration, weakness, not feeling good, or they could show up in shock depending on the severity of the bleed and the length of time they've spent attempting to manage this at home, thinking they would be okay. Once a varix has been diagnosed, they should have endoscopic screening every 2 to 3 years after initial diagnosis of esophageal varices. So these people require frequent follow-ups. Think about in this 2 to 3 years, you may say, well, that doesn't sound very frequent. But if you think about it in context, there are people who go their entire lives without having an EGD, an endoscope, for the upper gastrointestinal tract. You may go your whole life and never be scoped. And some people who have, for example, like an ulceration of their esophagus or stomach, would need a 6-month follow-up. And then if there's no evidence everything looks good, then they would only come back when needed. So this is a pretty routine, pretty aggressive follow-up structure for these conditions. This slide to the left here kind of gives you the pathophysiology. I don't care that you, a little more granularity. I think this is from your book, so it kind of gives you kind of a stepwise progression of that. I think I've summarized that for you. I don't care that you memorize this 12 millimeters of mercury or greater gradient. But what I want you to see from this slide is this picture. So what you have here is a bleeding esophageal varix, and I want to point out some things on this slide. So what you have here is this area over here is actually where the blood is landing. This is the bleeding varix up here in the top right corner, and you can see the blood is shooting across there, and it has enough pressure on it, enough force, that the blood, it's not just dripping down the side of the esophagus, it's shooting across with enough force that you can see it's creating this wave type pattern. So you can see how there's kind of a concave structure shape here and a crest of a wave where this light is being reflected. So it's the blood's hitting here, splashing up, and then draining down into the remaining portion of the esophagus on down in the stomach. Now, what I also want to point out to you here, which is not readily apparent, is this area of tissue right here. So if you'll notice that there's a portion of this that is blood, but if you notice up here in the more proximal portion that it's darker than this nice pink tissue. This pink tissue is what your esophagus should look like. This darkened area means that that tissue there is thinned and there's blood pooled behind it, and that is under pressure. So you can see where a varix of this size we could potentially treat. If this were to rupture, this could be very dangerous because it's a very large area of tissue that would be very difficult to try to get to quit bleeding. And in order to make it stop, might even require surgical resection if that were the case. The patient could tolerate it. So let's talk about the treatment of bleeding varices. And this has a progressive nature to it. So if there's a shock condition, if they're in some type of shock state, most commonly it's going to be hypovolemic shock, and that may require may require blood transfusions and or rapid fluid administration, and perhaps even massive transfusion depending on the severity of the bleed. So we're going to be administering oxygen. We're going to be administering oxygen, supportive oxygen therapy as aggressively as we need to. They don't necessarily have an oxygenation problem as a result of their lungs, but they may have issues with keeping up because their hemoglobin's so low. So we start with a cannula and progress from there, may ultimately end up intubating these patients. If the bleeding's bad enough and it's coming up in the form of hematemesis, we may have to intubate them to secure and protect their airway. So that's ultimately what we would do for the shock condition. Now we're going to start with IV fluids and monitor electrolytes, as you might suspicion, because these patients are going to have problems there. We're also going to be monitoring hemoglobin and hematocrit. We may use volume expanders such as albumin because there may be fluid in third spaces that we can recruit for these patients. And commonly they're going to get things like blood and blood products. Things like packed red blood cells in order to replace blood that's been lost, but they may also receive cryoprecipitate, fresh frozen plasma, and platelets. And if you think about that in context of what we've talked about with the liver, that makes complete sense, because one of the big things that I expect you to be able to free associate almost with the liver is when you hear liver problems, you think of bleeding. So if I say liver problems, your response is bleeding as one of the primary concerns. So if we are also giving coagulation factors like fresh frozen plasma, platelets, and cryoprecipitate, those products help facilitate clotting. Because not only do we have a varix that's bleeding, we have thin blood that tends to not clot very well. These patients commonly will experience one of these or a combination of these drugs to help manage or help improve the blood flow around this variceal area. And when I say improve, I mean try to decrease the pressure and increase the opportunity for the bleeding to stop. And I have listed here what these different medications do. We've talked about vasopressin as a hormone and its effect, antidiuretic hormone, on urine and urine retention. In certain doses, it decreases mesenteric blood flow, so it does produce vasoconstriction, and it draws blood flow away from and decreases the blood pressure in that area around the portal vein. So it can help help move some of that pressure away from the esophageal varices. Somatostatin also decreases GI motility and decreases blood flow into the splanchnic area. So that means that the gut is going to get less blood flow going in, which is ultimately going to lower blood pressure going into the gut and direct that blood elsewhere. And octreotide is going to constrict arterioles and venules, so it's going to constrict at the vascular level in the neighborhood of that varix. And sometimes you'll see patients on all three. So this drug does have a decreasing effect on portal hypertension, so you'll commonly see octreotide and vasopressin, octreotide and somatostatin, or sometimes octreotide at all three. Nitroglycerin can be used in combination with vasopressin. It can reduce coronary it does reduce coronary vasoconstriction, but it produces also vasodilation, which can decrease that pressure. So it can help those vessels in the splanchnic bed dilate more, and in turn, by dilating more, decreasing that pressure on the varix. You may also see beta blockers such as propranolol and nadolol to decrease portal pressure. Have to be careful when we start adding nitroglycerin and propranolol in these patients, as we may be having blood pressure problems to begin with, so we may not have a lot of latitude to give medications that produce vasodilation, actually lower blood pressure systemically. While their target is portal pressure, they do have a systemic effect. So sometimes those are not necessarily opportune for these patients. If the bleeding is severe enough and something aggressive needs to be done, but we need a temporary intervention to help stave off an acute event, then you may see balloon tamponade. I've not been involved with gastrointestinal bleed from a varix where we've actually tamponaded in order to get to the next treatment. Tamponade has to be done cautiously because balloon tamponade requires pressure on the esophageal tissue, and that tissue is already friable and fragile. So that could actually compound the problem. So that's done by a provider at the provider's as they decide their discretion. So the way we're going to begin to treat this, once we've kind of gotten some things stabilized and we can actually get in there, is what we refer to as sclerotherapy, which sclero means actually burning that tissue to try to prevent it and keep it from rebleeding. You may also see injection. I'm going to show you some pictures and walk you through that here in just a moment. Variceal ligation or banding is where we actually try to capture the varix, the tissue there, and band it up and allow it to heal. You may see the TIPS procedure, as I mentioned earlier, and then there's some additional augmental therapies that you'll see, proton pump inhibitors and things like that to help manage this going forward. And there may come a time where a patient has to have devascularization and transection or some kind of surgical intervention, surgical bypass, resection. Those are done in centers that are very thoroughly trained in that those surgeries. While that may sound like a relatively simple surgical procedure, it requires a great deal of skill and training, and not everyone does that. So here are some schematics of the esophagus with an endoscope, and you can see the esophageal varices here on the side. They look like these little pockets, and the reason they look like that is to reflect the thinning of the esophageal wall as a result of the dilation of those vessels around there behind it. And in this picture, what you see is a needle that's been extended here into the varix, in this case, that's bleeding. So if you look at this other picture to the right, We have two varics here on the bottom that are bleeding. These top two are not. You can see the little depiction of blood running down back here. What the physician is doing is extending the needle, and through that needle, he's going to inject epinephrine. So epinephrine given locally in a sufficient dose, a high dose for a local administration, but a low dose for systemic effect. So the patient doesn't get absorption and a big epinephrine response, adrenaline response. So locally, it is a quite sufficient dose to, if the varix is small enough to cause enough vasoconstriction in that area that it'll clamp down and stop the bleeding. The hope is, obviously with an intervention, less is more. The hope is with the less aggressive intervention, you'll have efficacy, but that may not always be the case. So this camera is a multi-tool, if you will. This is a little better depiction of the scope with the camera. And you can see this larger outer structure, that's the scope. And then we have a few structures here. So this metallic ring houses the camera, which allows the visualization to capture these pictures that you see. Then you have a device that extends that has two apparatuses. One is the needle, which we were just talking about, that's this very small structure at the end. And then you have this more blunt looking structure. The needle will retract. And so the needle is extended here. The needle retracts, and the tip of this catheter right here, once the needle's retracted, can provide sclerotherapy. So it provides that you run some energy, electrical energy through that in a high enough concentration, a focal enough area that it will cause burning or sclerotic formation of the tissue. So you have sequential pictures here at the bottom, A, B, and C, and picture A is the one with the red circles, and you can see back in here, there are some areas. Here's one within this circle, and there's one down here and a few others. There's another area right here, these darkened areas. Those are the varix. And if you compare this to the picture I showed you earlier, you'll automatically note that these varix are notably smaller than the very large dark red area I showed you, not to mention the one that was bleeding, but that really dark red area I showed you. So this is that dark red area showing up here as a varix. So what we've done, there's a slight camera rotation here, so it looks a little bit different, but what is happening in this moment is this portion of the camera of the device has the sclerotherapy portion has been extended and is brought up to contact with the tissue, and they're applying energy. And as they apply that electrical energy, you can see where the tissue becomes white and is basically being burned and cauterized. So that tissue is dying and basically burning off, so it will not, and scarring over, so it will not bleed again. They've done multiple areas, again, a slightly different angle, but these multiple areas here have been addressed and some that were not marked. But you can see these sclerotic areas where they were concerned, oh, this spot could bleed, or this one, and while we're in there, let's get them all, or as many as we can address at this time. So you'll notice you don't see near as many of these dark red spots in this last picture. You see a lot of white spots. And just for orientation, this one right here corresponds to where this initial burn was taking place. So that's what sclerotic therapy looks like. Now, the next intervention is if that varix is large enough that it would be dangerous to sclerose it. Because what you have to be concerned about here is when you go into this tissue and you start to apply cautery, if the varix is very large and you apply cautery, you may actually incinerate that tissue and cause the tissue around it to rupture, and then you have bleeding as a result of the treatment that you've done. So you need a treatment that's going to allow you to capture healthy tissue and pull it together so that it could scar over and heal. So in those smaller variceal areas, where you see cautery taking place, there's enough healthy tissue in close proximity to create scar and heal that up. With that first one I showed you where the varix was bleeding, and there was another varix below it that was very large. If we tried to cauterize that, it would blow up on us. So what we do in that case, if we can get a band around it, is we use this banding device. And you can see in this top image of A, there is your scope, and you see there is a suction catheter that's extended here, and that is to draw up gently that variceal tissue into this metal structure that fits on the end of the scope. That metal structure is like a bracket that allows that variceal area to be drawn up into that bracket. And you see this black band here in this picture as the ligating band that's on the very tip of that device. And the provider will pull a trigger, and that band then will tighten up. As you see in picture B here, the band will tighten up and create a puckered up area, which will ultimately obstruct blood flow into this tissue. So scar tissue will form on the healthy side, and then this tissue on the inside, the banded side, will ultimately necrose and slough off and pass in the stool along with the band. And you can see in this picture that I don't know exactly where the varix is here, and you can see they go in with the band and draw up the tissue, and now you can see the camera is rotated just slightly. You can see the banded tissue here, and the banded tissue here, and the blue area right here is the band. That's the band holding the variceal tissue, and ultimately this will necrose and slough off and fall away. Occasionally, an area is too large, like you see in this picture. There are multiple varices in this area, and there's a very large one here. There's a lot of blood here, so it's kind of hard to tell how big this is. Multiple areas that have the potential for rupture. So in this case, the patient was treated with what is referred to as a variceal stent. So you have a stent device that's applied inside the esophagus under high pressure. So it's embedded into the wall, and as it's embedded, it causes the metal to basically crimp off areas of bleeding, and the stent itself will endothelialize, and there will be basically a layer of tissue from the endothelialization here that will cover up those varices. So that would be another possible intervention here. So how are we going to manage these patients? We're definitely going to be maintaining a safe environment for them, preventing injury, bleeding, and potential sources of infection. That may look like initially a very mechanical soft or perhaps even liquid diet. Start with a liquid diet and progress over 24 to 48 and 72 hours. We don't want to introduce anything into the esophagus in a partially digested form that could potentially either knock off the scar tissue from the cautery and possibly remove the banding. There is another option too that's used a lot in conjunction with sclerotherapy, and that's clips, where they actually take a metal clip and clamp that area off. We're going to be monitoring for complications. We're going to be monitoring stool for continued presence of blood. Obviously, if they've had hematemesis, we're going to be monitoring for nausea and vomiting, and encouraging deep breathing, position changes, mobility, ambulation, all of those normal things that we would do